Hello.
Well, today we'll learn about intubation. So intubation is it's the placement of like an ET tube in the trachea. So I'm going to explain like who does it, when it's used, and then like kind of just the actual kind of how to. So it's a skill that's far more common than like people realize. It actually gets done like there's thousands of people intubated every day. If you've had surgery and you've like gone under for surgery, I can almost guarantee you that some type of airway was used. If it wasn't an ET tube, it was some type of airway. So so CRNAs and anesthesiologists are the ones that do it kind of in the operating room, and then me, I'm in paramedic school. So paramedics pre-hospital is about the highest, like that's the highest care you're going to get. So in the hospitals, it's the doctor, and then before you get to the hospital, it's a paramedic. So I'm in quarter 3 of that, and then I plan on going on to nurse anesthesia, which is CRNA. So be doing a lot of intubations on the daily. So the most common place, like I was saying, is in the operating room by CRNAs and by anesthesiologists. And like the overall reason, regardless of what it is the overall reason is just to secure the patient's airway. So I'll show you how the ET tube does it. But like as soon as you place that, there's a lot of decisions and like kind of critical thinking that go into it, because I mean you're taking away this person's ability to breathe, or you're restoring it and you're replacing it with like your own mechanical tube. So it's things you got to think about. There's a couple different ways you can actually get up to it. So I'm going to explain the equipment, kind of explain the how-tos of it, and then when and like why you do it in certain situations. So it is a pretty invasive procedure, and like in essence, the best way to describe it, like in layman's terms, is you really assume like the role of the patient's ability to breathe. Like so, it's either you show up and they're breathing on their own. So the biggest thing with intubation is as soon as you stick the blade like in their mouth to visualize their airway, there's risk of like if they have a gag reflex, they're not going to let you do it. So if you have a stroke, like let's say a patient's having a stroke and they're puking, they're aspirating, like there's stuff in the airway they're not able to protect anymore because of the injury. That's when something called RSI, which is rapid sequence induction, we actually push a sedative. A lot of times it's ketamine, and so you sedate the mind and then you push a paralytic. So then you like take away, like sometimes it lasts 30 to 60, but it's a neuromuscular blocker, so it's like you push a paralytic. You gotta be careful not to push that before the sedative, because the person like just can't feel anything and move, but like they'll be aware of what's going on. So you can imagine like how scary that'd be. So you gotta make sure like I said, it's a pretty complex procedure, but we are able to do it in the field. So if someone's not completely out and they still have a gag reflex and they're puking and I'm trying to, like you're trying to visualize it's just not happening, that's when you get IV access. You push those, and now you have a patient ready to be intubated, and you're all good. So a patient with no gag reflex and they're unresponsive, they're going to need the ones, they're not going to need like pharmacological sedation, which is pushing drugs and stuff like that. So you're familiar kind of with the grounds for intubation, and we're going to hop into the actual hands-on and what everything does. So this first thing is a BVM, a bag valve mask, and it's the gold standard really. Like if someone's not breathing, you restore it. So get a good seal right there. It's usually kind of the C if you're by yourself, one-handed provider. There's two-handed techniques and stuff like that. For the most part, you're going here, okay, patient's not breathing, get a good position the airway, boom. And you're getting a breath every 5 to 6 seconds, and it's going to be like, I could do this for theoretically, days. Like I'm sure the reason they're not breathing is probably past that, but theoretically, I could sit here and I could bag a patient. He's going to be perfectly fine. He's going to live for, you name the amount of time. So you always attach it to 100% oxygen. The biggest part of intubation, huge, is actually pre-oxygenation. So the goal of that is you want, it's called forced residual capacity. So it's basically the amount of time you have that the patient's oxygen is going to be circulating that before they start desatting, which is desaturating. So you want 100% oxygen. All of us, if you put a pulse oximeter on you, you'll be sitting around 98, 100%. And then there's two, it's kind of funny, but there's the names of them. There's 2 different types of blades. This one's called the Mac blade Macintosh, and this one's called the Miller blade. Just straight blade, so you got the Mac Miller blade. And this is the handle. You literally just connect to it, just like this. And then that light on the end, that's what allows you to actually see in the airway. And then the Miller blade is this one. It's a straight blade. You can see one's curved, one's not. and this one actually scoops the tongue out of the way for you. So this is the epiglottis right here. You can see that. So that's what opens and closes. Like when you breathe, it's open, and then when you swallow food, it goes like that. Food passes down, and it goes in the esophagus and your stomach. So this kind of lines up right here, and then you lift, and then you can. That's how you see the airway, and then that's where you pass the tube. This one, you actually pick the epiglottis up and like move it all to the side like that. So there's a slightly different technique in this one for difficult airways, because pre-hospital, it's usually, there's usually blood, it's usually a trauma, and like there's a lot of kind of other stuff you're worried about, and there's a lot more stuff that comes into play. So something as simple as BVM, that's a BLS skill, like EMTs can do that. However, there's actually a study, it was done in this book here, the Walls Manual of Emergency Airway Management. Been reading that, and so this is where I got all the stats from, and that's basically my bibliography. So there's only an 80% success rate after 25 attempts. It's an 80% success rate after 25 attempts. So you can see like that's only 25 attempts in the pre-hospital care. So like practice is the best thing for it. So this is an OPA. Another airway you can put in, and it basically facilitates the tongue off the back of the throat, so that way they're not snoring. Like when someone snores, that's the sound it makes, is just the tongue rests on the back of the throat. So if we have snoring respirations, all we have to do is open the airway, tongue's out the back of the throat, we're set. So, like that's the main, oh sorry, I forgot about the ET too. So this is the stylet, it's flexible. This stylet's flexible. Is that still recording? Oh, thank God. Okay. So this is a stylet, and there's another thing called a bougie, and it actually it's better for airway, like difficult airways, just because the easier pass. But this basically gives the tube shape. This is flexible. This is the ET tube that we actually connect to this, and that's what we breathe through. So this goes in here. It depends on how you like it. There's like you can form it different ways. There's some people like the hockey stick, which is like you basically straighten it out, and then you like give it a little lip at the end there. So it's really however, but and then so the reason it secures the airway, so this sits in what's called the carina, and that's where this your trachea comes down here, and then it branches off into the right lung and the left lung. So this is going to sit right about here. That's your goal. So if you push it too far, the right lung actually goes straight down, the left lung kind of comes off to the left. So if you push it all the way, chances are you're gonna it's called right main stemming it. So go like that, and then once it's in there, like it's just a tube. Like there's still space around it. So if you puke, it's still gonna go like in the trachea, and that's the biggest part is preventing aspiration. That's called. So you pump up the tube, and the cuff goes like that. So that's inside, and so now the airway is protected. All the air comes out down here, and you have a secured airway. So that's why, like when someone's puking and stuff like that, this is the gold standard to like now we got an airway. And so ABCs, airway, breathing, circulation, we got the A's covered. So now you're kind of familiar with the equipment for the most part, and then I'm gonna go into the actual technique and the actual how-tos. So there's good and a bad technique. The biggest thing is chipping the teeth. When I was in the clinical, I actually nicked a lip on a patient, because you'll see how easy it is to do. So this connects here. And it's very easy and tempting to like use the teeth as a fulcrum. So you're gonna position head tilt chin lift. That's called. It's in the books. It's all nice and you tilt it like that, but really you just open the airway. So you scissor on a real mannequin, like on a real person. The mouth's closed. It's not open like this mannequin. So you scissor. You come in. You visualize. Okay, so I got the tongue. This is what I'm seeing. I'm seeing this. So I'm at the base of the tongue right now, and I'm about to slip. It's called the vallecula, the area between the epiglottis and the tongue that I showed you. So if I rock back, it's really I'm giving that to the corner of the classroom. Like that's how you want to lift. I'm not prying, but if you do, like the mannequin's meant to like if this was a real person, that's how you chip teeth. So like that's the worry of it. So you remember like the anesthesiologist in the clinical and the OR, they'll tell you if they hear like if you start leaning like that, it's like they bump you or they hit you and they tell you to go up there. So that's a visualization. Pre-oxygenation, like I said, you're always going to start with that if you can. So you're going to pre-oxygenate, make sure you have plenty of time, so every 5-6 seconds. Boom, boom. Let's say he's at 100% SpO2. Now we're ready to actually intubate. Got my stylet and everything ready. Gonna go position the airway. Like I said, I have the epiglottis. Go. Hold that there. Don't take your eyes off the airway. Slide through the glottis, it's called. So now I'm through the vocal cords. I see it. Boom, we're in. I can pull the stylet. Connected. See, so if it's too far in, that's what I mean by right main stomach. So you back it out. Now we got both. So what I did is when that, you never let go of the tube, but for demonstrations purposes, I'm going to. So for that, I went too far. So that's what I mean by like, you will literally, this side won't go because you're not putting any air in it. So you got to back, I just backed it up, and so now it's sitting right about here. So I go there, boom, boom. Okay, got good compliance. Now you're going to puff up the cuff. Airway secured. Take the syringe off. And then you're going to usually secure the tube with tape, or there's commercial tube holders. And then you're just watching for, you have suction ready, watching for aspiration. Because if they puke, you still got the airway, but there's still going to be puke in there and you want to do it. So you, at this point, you're going to want to confirm. Easiest way to do that is just chest rising and falling. Like, you're just giving a breath. If you inhale, your breath rises and falls. That's the easiest way. Another thing you're going to see is fogging in the tube. It's actually like when you, on a cold window, it fogs up, same thing. So you go like that on a real person, more comes out. So then, and then we have EtCO2, it's called. So there's different ways to confirm that the tube is actually in the trachea and not in the esophagus. Because if it's in the esophagus and you give a breath, like you're going to throw up. So so that's intubation, and like I said, it's safe. I mean, doctors, we do it all the time, especially facilitated intubation. Like I said, if you've had surgery, if you had surgery, likely that's what you do. So it's safe. We know what we're doing. It's not kind of something that we just throw out there. And if you want, the mannequins aren't the greatest thing in the world, but if you guys actually are interested, I encourage you to just Google laryngoscopy. This is called, and you'll see the real airways. A real person's almost easier than these mannequins because it's more like they're more compliant and stuff like that. But I appreciate all you guys listening, and if you just want to show everybody, and that is that's the end of my demonstration.